Hello everyone. Today we are going to discuss about lower respiratory tract infection in children. What do you mean by lower respiratory tract? As I said, respiratory tract is divided into two parts, upper and lower. Upper part is from nose up to the epiglottis, upper respiratory tract. So from the nose up to the vocal cord and epiglottis is upper respiratory tract, and from the vocal cord up to the alveoli is called lower respiratory tract. As I said before, the most common infection in the lower respiratory tract for the children is pneumonia. In my previous video, I have discussed about pneumonia. So we will discuss rest of the infection of the lower respiratory tract. The most common infection other than pneumonia is croup. So what do you mean by croup? It is a peculiar brassy, barky sound produced during inspiration or during the child crying. So it is a barky inspiratory stridor sound. So what are the different types of croup is seen? There are two types of croup is seen. One is due to epiglottitis and other is acute laryngotracheobronchitis or bronchitis or laryngitis or tracheitis. So these are the conditions in which croup can be heard. So any inspiratory stridor that sound barky cough-like sound, then it is called croup. Why croup happen? Because the in the respiratory tract from a patient's nose, when the air enter into the nose and goes to the pharynx, and from the pharynx it's enter into the vocal cord. In the vocal cord, it produced in turbulence. In this airway, there is a turbulence is presence, and from this vocal cord, the turbulence is decreased to some extent. So, if there is edema in this portion, that means in the vocal cord there is edema, or in the epiglottis or in the trachea itself there is edema, then the turbulence gets increased and the air which is enter into the respiratory tract during inspiration causing a turbulence and causing this type of barky sound. It is called respiratory stridor. There are different causes of respiratory stridor in children other than infection. I will discuss in it later on. So, what are the different types of croup? One is acute epiglottitis, one is laryngotracheobronchitis. If there is edema in the epiglottis, then in the lateral chest X-ray on soft tissue of the neck, we found the epiglottis is swelled and which is looks like an thumb. So in X-ray we will found thumb sign in acute epiglottitis. In case of laryngotracheobronchitis, the bronchus gets edematous and the larynx also get edematous, and this causing there is decrease, and this cause there is decreased airway in the trachea. So the trachea is looks like so the trachea is just looks like constricted, and this is called stipple sign. Now come to the different causes of croup. First is acute epiglottitis. This acute epiglottitis is always caused by bacteria, and the most common bacteria which causes acute epiglottitis is Haemophilus influenza type B. The child is look sick, and due to there is a swelling of the epiglottis, the child having drooling of saliva. The child cannot deglute the saliva, and there is inspiratory stridor is present, and due to bacterial cause the child is suffering from high grade fever. The first, the child having common cold like runny nose and malaise, and after that suddenly the child having high grade fever with inspiratory stridor and there is drooling of saliva. Because the epiglottis is thickened, the epiglottis may also decrease the passage of the vocal cord, and the child will having some spasm, and the air will not enter into the trachea because of the spasm in the vocal cord, and this cause severe cyanosis. If we do direct laryngoscopy with cautiously, then we found that the epiglottis look like angry, red and swollen. This is also an MCQ. And the child having barky respiratory sound. If we do lateral X-ray of the neck, soft tissue lateral X-ray of the neck, we found thumb sign. This is also an MCQ. And the investigation is only lateral soft tissue X-ray, and we can do direct laryngoscope with cautious. It is not always indicated. The treatment of choice is giving antibiotic, that is third generation cephalosporin, that is ceftriaxone is the drug of choice, and we have to admit the patient as soon as possible. If the child is suffering from severe spasm and cyanosis, we start giving oxygen, and we will also need to do any tracheostomy or intubate the child. Now come to laryngotracheal bronchitis. This is mainly caused by virus, and the child is not that much of sick looking. The most common virus is causing laryngotracheal bronchitis is parainfluenza type 1 and type 3. This is also an MCQ. This bacteria enter into the body through nose, and they cause inflammation in the larynx, also the bronchus and the trachea, and there is shortening and of the airway, and this causes is barky, stridor, and the child is suffering from mild grade fever, and because of the shortening of this airway, the child is suffering from respiratory distress, as because the resistance is getting increased, the child is suffering from severe respiratory distress and cyanosis. If we do X-ray, then we can found that is triple sign. This is not lateral X-ray, sorry. This is straight X-ray of the soft tissue neck. You will found triple sign. That means the airway is look like constricted in the upper part. And the treatment of choice I will discuss in later on. So if you found stridor, always think stridor means problem in the epiglottis or the vocal cord or in the larynx. So any problem in the larynx causing stridor, or any problem in the upper respiratory tract also cause stridor. So if we found stridor during inspiration, then the child may suffering from different types of cause. If the child is afebrile, then think about foreign body aspiration, that the foreign body may dislodge and enter into the glottis or vocal cord and causing stridor, or due to hypocalcemia, the epiglottis may soften and causing inspiratory stridor, or angioedema in which the vocal cord is swelling up. If the child is febrile, then we have to see the high fever is high grade or low grade. If the fever is high grade, that means there is a bacterial cause, and the most common cause is epiglottitis or bacterial tracheitis or retropharyngeal abscess, each causing pressure effect and causing stridor to the children. If the child is suffering from low grade fever, then think about acute laryngotracheal bronchitis or diphtheria. So this is the protocol of diagnosing stridor. Now come to the severity of assessment of acute laryngotracheal bronchitis. The laryngotracheal bronchitis is divided into three types. One is mild to moderate, one is severe, and the last one is life-threatening. And the signs are, if the child is alert, that means the child is alert, active, and doing well with mother lap, then the child is having mild to moderate laryngotracheitis, and the respiratory rate is normal, and child is not having any stridor during rest. Only stridor heard when crying or when the child taking cough. The heart rate is also normal, and saturation is also normal. Then we are dealing with mild to moderate stridor. If the stridor is severe, then the child having lethargy. That means the oxygen is decreased in the brain, and the child is having lethargy. There is subcostal and intercostal retraction is present. The child having stridor also in crying or during coughing, or the child having stridor during rest also. The child having tachycardia and the saturation is normal. And in case of life-threatening, the child is agitated or unresponsiveness. We saw subcostal, intercostal, and also suprasternal retraction. The child having stridor during rest and also not improved after giving treatment. The child having bradycardia due to hypoxia and the saturation is also decreased without oxygen. So treatment is divided into three parts according to the assessment of severity. If the child is suffering from mild to moderate or mild, then we say the mother do not panic and also only give oral dexamethasone one dose at a dose of 0.6 mg per kg, or if we have nebulization in the hospital or in home, then only one time nebulization with budesonide at with 2 mg sufficient for the child. There is no need of giving antibiotic or beta agonist nebulization for this type of cruise. If the child is suffering from moderate to severe, that means mainly the severe group, then we have to hospitalize the child and we give adrenaline nebulization to the child. That means adrenaline is given in 1 in 1000 dilution. That means we give undiluted adrenaline, and also undiluted adrenaline is also given in angioedema. So this is also an MCQ. In angioedema and in group nebulization, we give undiluted adrenaline. The dose is 0.5 mg per kg. Maximum we can give 5 ml. If we need to give second dose, then we can repeat after 2 hours. And we also give steroid, because steroid decreases the inflammation of the vocal cord and the larynx and trachea, and it is given at a dose of dexamethasone 0.6 mg per kg, oral or IV or IF. If we give nebulization, then it is budesonide 2 mg. Dose is same for all ages. Adrenaline is given to decrease the vasoconstriction and decrease the edema in the larynx and vocal cord and also the trachea. And steroid is given to decrease the inflammation. So this is the treatment protocol. If the child is suffering from mild flu, then we give only oral dexamethasone and we send the patient to home. We do not need to admit the child. If the child having moderate to severe flu, then we have to admit the child giving adrenaline, nebulization and also steroid. So steroid is the treatment of choice for flu. If the child having flu during rest, then we have to only give adrenaline nebulization. Otherwise, we can give only oral dexamethasone. Is sufficient to decrease the inflammation of the flu. So this is the treatment protocol. So this is the different types of lower respiratory tract infection.